Welcome to Pharmacy to Dose, the critical care podcast, where we're discussing critical care and its pharmacotherapy in a fun and entertaining manner. Now, each episode, we summarize the available evidence, discuss controversial issues, and provide practical take-home points with a subject matter expert. And I'm your host, Nick Peters. And wherever you are and however you are listening, thank you. QXMD builds mobile solutions that drive evidence-based care in clinical practice. So check out Read for easy access to research personalized for you. Calculate for over 500 easy-to-use decision support tools, and Learn to earn CME online in minutes per day. Try them today at qxmd.com/apps. Again, that is qxmd.com/apps. Now, a couple housekeeping items before we get to our awesome guest today. Now, I teased this on Twitter, and if you don't follow the pod, it's a good way to stay informed. So that's at Pharmacy to Dose. But the next podcast will be a 2-part episode trying to find the best medication in critical care. Now, how are we going to do that? Well, it's March Madness time. So we created a bracket of 68 drugs used in critical care. I'm sure you're probably wondering, who is we? Well, we consists of Melanie Smith, Matt Robertus, Brian Gilbert, and Josiah Smith. Now, if you're maybe not familiar or don't know who these incredible critical care pharmacists are, they'll get a proper introduction at the beginning of the episode. Don't you worry. But to give you kind of a behind-the-scenes sneak peek, we're going to have 4 different regions. So we have like a cardiac or cardiovascular, infectious diseases, pain, agitation, delirium, and then like a potpourri, kind of, things that may not fit in its own category, but obviously are still very important. And just like they do for the actual NCAA tournament, we're going to have the same analysis, dissecting the top seeds, maybe who got snubbed, the 5 versus 12 upset special, sleeper teams, who's overrated. And when I say teams, I obviously mean medications, of course. But more to come on this front. I think this is going to be so much fun, an absolute blast. And there's also going to be a bracket or like Twitter polls for the listeners to kind of fill out. So we'll have kind of the special guest bracket of the 4 guest hosts who really help. But then we'll also have a listener bracket, and we'll kind of see how that lines up. And then finally, this episode's being released during the heart of our discussion on 12 Rules for Life and Antidote to Chaos by Jordan Peterson. So that's the Pharmacy to Read book club. So follow us on Twitter and definitely join the Goodreads group. It's called Pharmacy to Read on goodreads.com. If you'd like to be a part of the discussion of this, the Pharmacy to Read kind of co-host or co-lead is Andrea Newsom. You may remember her from the awesome ARDS episode. And there's a chance we may even record a small pod kind of talking about it. So stay tuned on that front. Now, the real reason that we're here today, I'm lucky to be joined by a friend of the pod, Heather May, discussing immunotherapy toxicities in the ICU. Now, Heather's a critical care pharmacist in the immunocompromised ICU at the Mayo Clinic in Rochester, Minnesota, and assistant professor in the Mayo Clinic College of Medicine and Science. She's pursuing a master's degree in clinical and translational science, and her research program focuses on critical illness complications of chemo and immunotherapy, including tumor lysis syndrome and chimeric antigen receptor T-cell toxicity. Heather has served for 6 years in residency program leadership and is also a fellow in the American College of Critical Care Medicine at FCCM. And on top of everything else that she's doing, she took time to join all of us today. So thanks for joining us, Heather. How are you doing?
I'm great, Nick. Thanks. How are you?
I'm doing fantastic. It's a little, I don't want to complain about the weather because everything pales in comparison to Minnesota winter. So I'll just say we're recording this on a Friday. It's a happy Friday kind of day.
Well, that's good. It's pretty sunny here too. And by all standards, winter in Minnesota hasn't been so bad this year.
All right, there we go. Now, some of our listeners may not know, but you've told me that you've kind of been infected. Now, you may be contagious, but this is not the coronavirus. It's actually the travel bug. So what would you say is one of or some of your favorite countries to visit?
Well, I think probably one of the most beautiful places in the world is Bora Bora. It should definitely be on everybody's bucket list. It takes a lot of time and resources to get there, but it is 100% worth it. But otherwise, coronavirus aside, anywhere in Italy is probably one of my favorite places.
What was your favorite city in Italy?
I think I would pick Florence because I love the architecture, the art history that's there, and their food is amazing. The focaccia there is out of this world.
You know, I'm married into an Italian family. You know, the last name has an apostrophe, it ends in a vowel. I mean, everything. And so when we went to Italy, it was just an incredible trip. And I agree. I thought Florence was, obviously we would go back to any Italian city. I mean, we were literally on like the European version of Zillow looking at, how much would a house be? Like, how could you be an international pharmacist? Now, follow-up question. You're in Italy and you can only either have pasta or pizza. What's your choice?
Well, I would probably go with pizza. I think pizza is probably my all-time favorite food. And seeing as you can get so many varieties, I think I would have to go with pizza. And I'm jealous, by the way, of you getting to tour Italy with someone that is from there and has family that's from there. That sounds like a dream.
Behind the Honeymoon is one of those once in a lifetime trips. Absolutely. Now, I wasn't expecting you to say pizza was my answer. I wasn't expecting you to say pizza, but once you've had it there and how it's so simple, like it's just a simple cheese or margarita, and it is that wood fire, it is incredible. I had a hard time eating pizza when I came back because it's not the same.
That's true. You just give it a little time, and then after will make the heart grow fonder. Plus, maybe you get tips from your wife and her family about how to capture that at home.
Now, do you have a favorite Italian place or in Minnesota, or are you kind of on the side of preferring kind of homemade, home-cooked Italian?
My preference is generally homemade, home-cooked Italian, and I'm not great at it, but I've got friends who are extremely good cooks, and between the three of us, we managed to put together a pretty good Italian feast, I think. But there is at least one place in Rochester that does some of the homemade pastas and things. So that's my fallback when I'm feeling unambitious in the kitchen.
This is a recurring theme throughout this basically show, is that it's not what you know, it's who you know, whether it's pharmacy or food. Now,
That's right.
Now, you and I also, I found out we have similar tastes in music. We're fans of kind of the indie music scene. So who would you say are, maybe some of your favorite artists or bands?
Well, it sounds like we share a favorite in Florence and the Machine. So I knew you had great taste.
I absolutely do. Have you had the chance to see her in concert yet?
I have. So I think one of the most memorable times that I saw her was at Lollapalooza a few years back, and there was this crazy lightning storm, and they were trying to get everybody out of the park and trying to get her off the stage. And watching this incredibly expressive artist run around the stage and the crowd singing Cosmic Love in the middle of this epic lightning storm while people were trying to get us to leave, it just literally gives me goosebumps.
That's so funny that you mentioned that it's her energy and like her presence that stands out, because I've seen her once, and I think it was during Shake It Out. I can't remember the exact song, but she literally left the stage and just ran through the lawn and is like hitting these notes that I can't even hit in my dreams. And she's doing it as she's walking through the lawn of like a concert venue. It was, incredible albums, incredible music. If people listening haven't had the chance to listen or find her yet and her band, it is top notch. Do you have a favorite album of hers?
I don't think I loved them all, and there's always, a song or two on each that will, be forever favorites.
That's how you know they're a great artist, when it's like, I can't choose. If it's a desert island, I'm just going to have to kidnap her. I can't choose just one album.
Yeah, I just take them all. Just take them all.
Okay, so kind of the real reason that we're here today is to kind of learn some expertise from you. Now, most of us, I think, in the world of critical care pharmacy are somewhat familiar with many of the oncologic emergencies, such as tumor lysis syndrome or maybe hypercalcemia of malignancy, superior vena cava syndrome. But with the invention of new treatments that I think, judging by email updates, happen just about every week, there have been two new kind of emergencies that have become hot topics in the oncology and critical care world. And I think that's what Heather and I are going to specifically focus on today, which is the chimeric antigen receptor T-cell complications and toxicity, or we'll probably refer to it on the podcast, and you may see in the literature as CAR-T. And then immune-related adverse effects from the immune checkpoint inhibitors. That was a mouthful. Now, Heather, before we even dive into these topics, what kind of immune system primer do you think we need to make sure this discussion doesn't breeze right past myself and maybe the listeners? I'm more concerned about myself.
Well, that's fair. This is a unique challenge, trying to tackle the complex topic of cell signaling without the advantage of a diagram, but we'll try it here. So I want everybody to think back to a picture I'm sure you've seen where a half-moon-shaped T cell is presenting a Y-shaped T cell receptor to an antigen of some kind. And remember, antigens are expressed on everything from our own tissues to bacteria to tumor cells. So most of us remember the connection that's being made between the T cell receptor and the antigen, which we call signal 1. But what's often forgotten is that there's another connection happening at the same time that determines whether a T cell will become activated or inactivated. And this is called signal 2. So the second signal involves another receptor on the T cell binding to a molecule on the antigen presenting cell that either signals T cell activation, which is what we want when our bodies are fighting off infection or eliminating mutated cancer cells that are precursors, or that second signal can cause the T cell to become permanently inactivated. And if you think about why we might have a mechanism to inactivate T cells, it's one of those things critical to maintaining homeostasis, part of checks and balances to make sure that we don't have uncontrolled cell proliferation in our immune system, which would be deadly. So again, to reemphasize, in addition to the T cell receptor antigen connection, there's that second signal happening that either involves co-stimulatory or co-inhibitory signaling. So both CAR T cell therapy and immune checkpoint inhibitors, along with hematopoietic cell transplant, actually fall under the umbrella of immunotherapy. And the basic concept of immunotherapy is that we're arming an individual's own immune system to fight their cancer. And so we'll talk more about specifically how each of these treatments do that.
Well, without having visual aids, I think you just did a fantastic job. And when I read the phrase, the name chimeric antigen receptor T cells, kind of sounds like that could be like an old dinosaur, or maybe like an 80s action movie, or like a villain or something like that. So how do these chimeric antigen receptor T cells work?
So it's a very new and innovative process, even if it sounds like an old 80s action movie. So basically, a patient's own T cells are harvested and then bioengineered to express a T cell receptor that's designed to recognize and bind specific tumor antigen with a very high affinity. And then additionally, they're made to express a co-stimulatory signal 2 domain, like CD28 or 41BB. And that interacts with the corresponding molecules on the tumor cells to cause T cell activation and proliferation. So patients get pre-treated with lymphodepleting chemotherapy, and then these bioengineered cells are infused. And we call CAR T cells effector cells because once they're activated, they migrate to the tumor and start killing tumor cells by release of cytotoxic granules and proteins. That's why you'll sometimes hear CAR T referred to as immune effector cell therapy. And there are currently 2 FDA-approved products out there. There's absicaptogene cilolacel and tisagenlecleucel, which are both being used to treat either acute lymphoblastic leukemia and then relapse refractory B-cell lymphomas. So that said, the indications for these are expanding rapidly, and there are probably 2 more products that will be approved in the upcoming year, and I'm just hoping they come up with names that are a touch easier to pronounce.
So I was going to ask you this earlier, but since you said that, I'm going to slide in and put this in right now. Kind of ask this now. So when you kind of get into this oncology world, is it something like, do they give you a handbook, or how are you able to pronounce them? You know, I understand the mobs and maybe the first syllable, and that's about it. I mean, or is it one of those where it's like a sink or swim type of thing?
Yeah, tisagenlecleucel is a mouthful. And as a disclaimer, there are multiple different quote-unquote correct pronunciations espoused on the internet. So I would say that I've done my best, but I can't be held accountable. Regarding kind of all of the tough naming, the secret, I think, is to fake it till you make it. Because likely there's not somebody on your ICU team that is going to be confident enough to correct you out loud. And I also figure that for all of the times we have heard mispronunciations of things like anidilafuntin, the pharmacist should get a free pass.
The fact that there's multiple pronunciations is just almost unfair. Because you have somebody who you're giving a presentation, you know, you're going to Google it, and then you have 2 things, and it's kind of like, you just hope, I guess.
Yeah.
Now, when you're talking about this kind of T cell therapy, so modifying someone's own T cells probably creates some unique side effects compared to, I guess, what we'd call more classic chemotherapy. But that's probably an episode all in and of itself. So maybe specifically, what types of adverse effects from this therapy are most likely to put patients into the ICU?
So broadly, the 2 most common toxicities specific to CAR T therapy are cytokine release syndrome, which we often call CRS, and neurotoxicity, which is commonly being termed ICANS, which stands for immune effector cell associated neurotoxicity. So you could say either ICANS or just neurotoxicity, either is fine with me. However, infection and sepsis are also happening in these patients, and we've seen other critical illness complications like HLH reported in the literature, but it's mostly CAR T and CRS and ICANS that you'd worry about.
Now let's kind of start our discussion focusing on the cytokine release syndrome or CRS. Now, at what point after the CAR T cells are infused does this typically happen? And then maybe how acutely do these patients present? Is it something where, you know, it's like severe ARDS or, you know, refractory septic shock where they are coming and they are very critical very quickly? Or is it something that maybe takes a little more time?
Sure, both good questions. So when you think about cytokine release syndrome, it's an exaggerated inflammatory response that is caused by excessive cytokine release that happens because of T cell activation. And it usually occurs within the first 1 to 2 weeks following CAR T cell infusion, though symptoms typically start pretty shortly after cell infusion. So in the Juliet trial, the median time to onset was 3 days, and in Zuma 1, it was 2 days. So generally, the patients will present early. And the hallmark features of CRS, first and foremost, is fever. And the others are things like tachypnea and headache and tachycardia and hypotension and even rash sometimes. So these can vary in severity that we describe using a grading system of grades 1 through 4. So whereas grade 2 includes fever and hypotension that doesn't require vasopressors or something like low flow nasal cannula for respiratory support, you'll see grades 3 and 4 are what is bringing a patient to the ICU for either pressor support or high flow nasal cannula or something like non-invasive positive pressure ventilation. So the larger trials would indicate that the symptoms on average take about 7 days to completely resolve, but only recently has a grading system been agreed upon by the American Society of Transplanted Cellular Therapy So it makes it hard to harmonize the incidence of each grade in the existing literature. But several of our real-world trials that have been presented recently indicate that grade 3 to 4 cytokine release syndrome probably occurs in somewhere between 10 and 18% of patients. And you asked about progression, and this isn't something that's well described in trials, so I'll admit I'm answering this based on my experience at our center. Some patients will certainly decompensate quickly, and you have to be ready for that. It's important to have processes in place to deal with rapidly decompensating patients effectively and efficiently. But others are going to smolder with grades 1 and 2 on the general care floor and either maybe never warrant ICU transfer, or perhaps the transfer will happen because of ICANS that is occurring at the same time, or perhaps it looks like a patient is about to imminently progress to another stage, or maybe they're right on the precipice and we're giving a lot of fluids, so we're worried about their respiratory status as a result.
Now, are there certain people or patients that are more likely to experience the cytokine release syndrome?
We have some information on that. I would call the data robust, but results from our secondary analysis of larger trials and the smaller studies suggest that we can tentatively say a few characteristics seem to increase the risk for CRS. Ones that come to mind are higher CAR T-cell dose. Patients that have a lot of tumor bulk are a little bit older, and then the type of lymph node depleting chemotherapy. So specifically, if fludarabine is included in the regimen, these perhaps increase the risk, and it may be that other baseline comorbidities can impact the risk, or at least how well patients tolerate cytokine release syndrome.
Now, kind of a follow-up here, but do you, when I say you, I guess more of kind of the team, but, do they prepare for these adverse effects regardless if if these patients have those risk factors or not?
Yes, I think we're pretty familiar with the chance that patients can experience either CRS or ICANS, and so different places probably prepare different ways, but we have transfer protocols in place. A lot of places that are doing CAR T-cell therapy have worked up treatment protocols and have started, good communication networks between the hematology team and the ICU team. And so you definitely have to prepare. We'll talk a little bit more when we talk about treatment of CRS, about how we have to prepare on the pharmacy side in terms of having certain medications available. But yes, part of being an accredited center that can do CAR T-cell therapy is demonstrating to an accrediting body like Joint Commission or ASHP residency accreditors that indeed you can handle and you're ready for these side effects.
I didn't know that was a kind of part of the process, is getting kind of approval from governing bodies, but I love that. The fact that you're manipulating someone's own cells, we shouldn't be able to do that everywhere. So that sounds like something good. Good
right.
process.
We don't do that lightly.
Now, CRS, kind of from what you described, fever, hypotension, maybe some respiratory distress, it kind of can mimic a lot of other kind of classic ICU presentations, like maybe, sepsis or even trauma patients. And so do we have any biomarkers that can kind of help us identify CRS and maybe rule out other potential causes or diagnoses?
Well, unfortunately, at this point, there's no pathognomonic indicator of CRS. One of the more helpful tools can be cytokine studies, if your center has the capacity to do them and run them regularly. So levels of interleukins 2, 6, and 10, along with interferon gamma and tumor necrosis factor alpha, have all been shown to be elevated in the context of CRS. Of the more mainstream tests, so patients with CRS often have increased levels of ferritin and CRP, and we've seen that CRP is correlated nicely with IL-6, so abrupt elevations in either of those could indicate underlying CRS. And then procalcitonin is one that people have wondered about, and of course, that is probably a whole other discussion in and of itself. I know of at least 2 ongoing studies that are looking at the use of procalcitonin in differentiation between sepsis and CRS, though to my knowledge, I don't believe preliminary results have been made available. So this is another area I expect to get more information in the coming months. But for now, at least, I take this kind of laboratory and biomarker data and consider it in the context of the bigger clinical picture rather than relying on it to make my diagnosis.
It kind of sounds like you're doing, the same practice that we do with a lot of our other biomarkers, is you use that as an additional piece of evidence, but you're not going all in if someone has a high CRP, for example.
Yep, exactly.
Okay, so we've identified, or maybe we highly suspect, right, that this patient has some risk factors for CRS, so we suspect that might be happening. What's our next step? What do we do at that point?
The treatment of CRS is going to be largely determined by the grade. Remember, I said grades 1 through 4 are how we've categorized them. And there's no official guideline recommendations right now. We're awaiting these from ASPCT. But I'd say there's a great paper in Critical Care Medicine that outlines the framework for supportive care, which is really fundamental for both hemodynamic and respiratory support. And our colleague, Anne-Rain Tanner-Brown, just gave a very nice talk at FCCM and shared the MD Anderson protocols, which have been made publicly available on their website. And so the listeners can go and reference those if you want a look at how one center handles their CRS treatment. So beyond good supportive care like fluids or pressors or diuresis, if it's safe and necessary for a respiratory or cardiac status, the targeted FDA-approved first-line agent we have is called tocilizumab. And it's a monoclonal antibody that binds soluble and membrane-bound interleukin-6 to reverse symptoms of CRS. And we think a dose of 8 milligrams per kilogram is certainly to be indicated in patients with grade 3 CRS and above. But our real-world data suggests we're actually giving it earlier and earlier, so often in patients with grade 2 CRS, in an attempt to prevent progression. And there's at least one pending trial evaluating the optimal timing of that intervention. I said we need to be prepared as pharmacists to manage these toxicities, and so the CAR-T-REMS program mandates that an institution has to have 2 doses on hand for every patient that is receiving cells. Tocilizumab can be given up to 3 times, but generally if a patient fails to improve after 2 doses, we might start looking at a rescue agent. So right now, rescue agents that we would consider are cetuximab, which is another monoclonal antibody that binds circulating IL-6. There's also anakinra and steroids, as well as a couple compounds that are sort of in the preclinical stage being investigated. So our data suggests that short courses of steroids actually will not be resulting in negative effects here. So there was originally some concern that steroid use might suppress CAR T-cell replication and impact outcomes negatively. Fortunately, some of the newer data, a lot of it's been presented in abstract form at ASH recently, but it's suggesting that both outcomes as well as T-cell response and expansion hasn't been affected by shorter courses of steroids. And of course, that makes sense given, again, that we have a hyperinflammatory pathogenesis, and so steroids make sense to address that. So there are other groups indicating that they are studying the impact of steroid use earlier in grades, and so perhaps those could be used to prevent the advanced stages of CRS. We're still learning a lot about that. I would also shift directions a little bit and say that in reality, we're also working up infection at the same time as we're working up cytokine release syndrome. And at FCCM, I shared experience from our center that describes nearly 80% of the patients transferred to the ICU receive antimicrobials, not just as prophylaxis, but actually as empiric coverage. And so we're often expanding antibiotic coverage when they transfer to the ICU, which I do think is important. There was a study recently published in PID by Park and colleagues that showed in a cohort of 53 patients, over 40% of them experienced an infection within the first 30 days from their cells. Most of these were bacterial, but fungal infections also occurred during that time period. And so although the study was small, results do suggest that there's a correlation between severity of CRS grade and the presence of infection, particularly bacteremia. So while we may strongly suspect that it's CRS, and perhaps it is, that doesn't mean we should neglect a sepsis workup, because both of the things could be happening at the same time.
Well, and the last thing you want is to miss potentially, like misdiagnose and lead to, 36 hours of no antibiotic coverage and when someone turns out to be, a septic patient. You don't want to miss that. So that completely makes sense. Kind of if someone comes with respiratory distress, they might get some antibiotics as well for a little bit to empirically cover. So that definitely seems reasonable. Now, are these agents that you kind of described, like tocilizumab, and are those going to be more of like restricted and have kind of local protocols? Because I imagine without any guidance that people could probably run a little wild with these agents.
That's true. There's generally ones that people aren't used to giving, and particularly in an ICU setting. We don't give a lot of chemotherapy in the ICU, or when we do, it's under strict protocols. And so this is one of those things. And when I talked about being prepared to manage these patients, one of the steps certainly is putting the protocols and the processes in place to help providers be comfortable ordering them, help nurses be comfortable hanging them, help the pharmacy be comfortable, getting the med ready quickly and getting it to the floor. So there is a lot of process planning that needs to go into using some of these things, since they're not exactly run-of-the-mill treatments. And even steroids, because there was that question about whether or not steroids were ultimately going to decrease the effectiveness of the CAR T therapy, we need to be having a conversation with the hematology group and just double-checking that steroids make sense. And although fortunately it's looking like maybe short courses are not going to cause harm, there's always a trade-off. And so, again, maintaining open communication when you're deciding on how to manage patients, but also doing so efficiently, because you can't stand around twiddling your thumbs. It's really important.
Now, the other severe adverse effect from CAR T therapy that you mentioned is, I'm going to call it neurotoxicity. I'm going to leave the formal name aside. But when would kind of neurotoxicity present, and do the symptoms range in severity, or do they generally present with one classic presentation?
So this is a truly unique toxicity. It can present in the early phase, often concurrently with some grade of CRS, but there's also a delayed presentation that can develop as far as 8 weeks out from CAR T-cell infusion. And symptoms usually start with tremor or dysgraphia, meaning that patients have poor and illegible handwriting, and maybe mild difficulty with speech, something like naming specific objects. And then this can progress to expressive aphasia, meaning the inability to speak, which is one of the hallmark symptoms of ICANS. Patients can also be inattentive or lethargic, and they may have apraxia, meaning that they're asked to perform a movement and they understand the command, but they're actually not able to use their motor skills to do it. There's also encephalopathy. This is a very dominant feature, and patients with severe toxicity can actually have seizures or elevated intracranial pressure and cerebral edema, which unfortunately is often fatal. I do get the question, can ICANS look like hypo or hyperactive delirium? And that is true, specifically when patients are experiencing that depressed level of consciousness. But neurotoxicity with CAR T-cell therapy typically contains some of those unique features I talked about, like dysgraphia or speech difficulties. And similar to cytokine release syndrome, ASTCT recently developed a standardized grading system that does take into account evaluation of speech and motor function and orientation and levels of consciousness, and as well as findings from brain imaging. And it's a little bit complex to explain in detail in this setting, but I'd encourage you to reference the consensus criteria that are published by Lee and colleagues in the biology of blood and marrow transplant last year, or you can download a great app from ASTCT, which has an easy-to-use grading calculator. So the last thing I'd say about frequency is that, again, our real-world trials are describing slightly different frequencies of advanced grade toxicity here, the type that we would manage in the ICU relative to the earlier phase 3 trials. And so it looks like maybe grade 3 to 4 ICANS, which include things like severe aphasia, the inability to follow commands, evidence of seizures or brain swelling or coma. That seems to be occurring in maybe 30 to 40% of patients, so a slightly higher incidence than CRS. But there has been some abstract data reporting surprisingly low rates, around 4%. So again, I think this is still a moving target.
You mentioned the presentation, it could potentially be confused for different forms of delirium. The first thing I thought of was a stroke, like a code stroke, in terms of
right.
like aphasia and things. Is that common? Does that happen?
We haven't seen anybody present with a stroke at our center, and I think just because this toxicity is sort of expected and the symptoms generally begin with some of those mild things like tremor or difficulty naming objects, we generally have a higher threshold to initiate stroke protocol, but we do get neurology involved when we're managing these patients, typically early, because this is maybe one of the more severe and deadly and complex toxicities to manage. And so, fortunately, our neurology colleagues are with us every day, examining the patient multiple times, and are acutely aware of changes that would suggest stroke versus neurotoxicity.
It's really lucky that the neurology team is with you, kind of rounding and on these patients, because this particular kind of presentation sounds both scary for the patient and even like family members and things and the team, and then kind of like you said, unique to CAR T cell therapy. So do we have any idea why this happens?
Well, unfortunately, this is still a little bit of a mystery. Our educated guesses are that cytokines like interleukin-6 accumulate in the brain, or perhaps the CAR T cells traffic into the CNS. And then there are some indicators that higher grades of CRS predispose patients to ICANS as well. So we have some theories, and we're working on understanding it better. Given the frequency and severity, this is a big push to invest a lot of effort in understanding it better so we can figure out how to dial in our effective care.
Now, are there risk factors that increase, the chances that patients may experience the neurotoxicity?
That's a good question. It seems like older patients are at risk, along with those who have some degree of cognitive impairment at baseline. We have discussions about the appropriateness of candidates for CAR T cell therapy, and so we do pay a lot of attention to their baseline neurocognitive status. And then, like with CRS, higher tumor burdens and cell dose may play a role here, and then, like I mentioned, patients with higher grade CRS seem to be at higher risk for neurotoxicity. That's what we think we know so far.
So even though these complications are very unique, and the side effects, the risk factors, they have some overlap. So can patients experience both?
They can, yep. So particularly in the early phase, after cells are administered, you can see cytokine release syndrome and ICANS happening at the same time. But then again, oftentimes ICANS can present further down the line as well. So it's sort of a bimodal distribution. And in the later phase presentation, that's usually neurotoxicity by itself.
Now, can you treat the ICANS the same way that you treat the CRS since they're complications kind of from the same therapy?
The treatment for ICANS actually follows a little bit of a different pattern, though there are some similar players. So unlike CRS, tocilizumab is not the treatment of choice here. So it may be warranted if CRS is presenting at the same time as ICANS, and maybe the CRS is progressing towards a higher grade. And I bring this up because there's this thought that tocilizumab may actually worsen ICANS symptoms by leading to higher circulating blood levels of interleukin-6, which could traffic across the blood-brain barrier. So overall, more research is still needed on that topic. But I will say that we don't think that isolated ICANS symptoms will respond to tocilizumab alone. And so that, I guess, is a place to start. Instead, we are using steroids more so as the mainstay of treatment. So similar to CRS, there are no universally accepted guidelines here. Most protocols will call for the initiation of steroids, and I've seen most often dexamethasone at doses of between maybe 4 to 6 milligrams every 6 to 12 hours when symptoms first appear. And then oftentimes these doses will increase to 10 milligrams every 6 hours or so when ICU monitoring is required. And for the most severe toxicity, some centers are giving up to 1 gram of methylprednisolone per day, and we have to switch formulations because of the poor tolerability of dexamethasone at those high equivalent doses. And then in addition to steroids, a lot of places are using seizure prophylaxis. So again, that's not universal. We use Keppra at our center, and we usually start with a dose of 500 milligrams every 12 hours, but we'll escalate that dose up to 1 gram every 12 hours if ICANS symptoms are severe. The other thing that's key here is early brain imaging when patients are decompensating, because we want to be able to catch the cerebral edema early, because when those cases have been reported, they can often be fatal. And so once you get to treatment of cerebral edema or seizures, most centers are falling back on their existing protocols for management of those conditions. There's not really specific recommendations for patients with CAR T-cell therapy that are experiencing cerebral edema or status epilepticus or things like that. So we kind of just fall back on a regular old ICU experience there.
That's an important point that you said, that the treatment of CRS, if you use that for ICANS, could actually worsen symptoms. So a really good thing to highlight. Now, understand it may differ based on practice site or hospital that you're in, but where are most of these patients located who either are receiving actively either the chemo or the T cells, or who have already received the CAR T therapy?
Sure. Most of the patients who are getting CAR T-cell therapy will be kept close to their center, particularly in the 30 days or even more after cells are infused. I talked a little bit earlier about how CAR T-cell therapy is being given at accredited centers. And when you get that therapy, most patients will be given specific instructions about where to receive treatment if they think they're experiencing a complication or a symptom that requires medical workup. So, for example, we tell our patients not to go to the emergency department, but rather they contact an on-call provider 24 hours a day if they think they're experiencing a concerning symptom. So this means that at least at this point, patients who have received CAR T-cell therapy probably won't be found in your rural EDs or ICUs or even in academic medical centers that aren't yet providing therapy, at least not in the immediate cell infusion time frame. But given that CAR T is really considerably extending life expectancy, it is possible that people encounter a patient with a more remote history of CAR T-cell therapy. And in this case, it could be very possible that they're just experiencing another medical emergency unrelated to the therapy. But I would say that because of some reported cases of that delayed neurotoxicity, you could be considerate of that. And then there are some chronic complications like hypogammaglobulinemia, which can lead to infections, those sorts of things that would be a unique consideration if you run into a patient that has received CAR T in the past.
And if this patient comes to, like you said, maybe that rural ED, other than if you in the patient intake, they say they received CAR T therapy, if you're not one of those centers, realistically, there's probably absolutely no way that you would know and be able to kind of treat that. Would you agree, or do you disagree?
Well, a lot of patients will actually have identification bands or, like a wallet card or things that indicate that they're receiving CAR T. And then in our center, at least, we use Epic, and so many of our systems are interconnected. And so if they presented to a rural emergency department that was on our Epic system, there would be a banner, something that would flag. But hopefully patients and their family members or their caregivers are pretty well educated to provide a thorough history to providers in that instance. And if you do run into a patient that has received CAR T cell therapy and you get your hands on that information, it hopefully would be documented in the chart or shared by the patient or family members, contacting their primary hematologic provider or somebody from the treating center would be a good thing to do, because even if the complication has nothing to do with CAR T cell therapy, maybe they're just having chest pain because they also have coronary artery disease, maybe that patient would warrant follow-up specific to their malignancy at some time after the acute situation has passed.
When I was a critical care resident, I did a transplant rotation. That sounds in line with what they told me, is like if you have a patient who has a recent organ transplant presents to their ICU, one of the first things you need to do is call that team. And that sounds like, just like here, one of the first things you need to do if you find that is to call the primary team, right? Because it's a complicated therapy. They want to know everything that's happening. That's a really good advice for all of us.
Exactly. We invest a lot of energy and resources, and our efforts. These patients go through so much to get the therapy that essentially we just all want to sort of protect their future and their safety. And so even if their acute illness has nothing to do with their therapy, we often will see them just for very routine checkups and cancer screening and that kind of thing.
Now let's shift gears here and talk about the immune checkpoint inhibitors. Now, what are some examples of checkpoint inhibitors? And then for those who, like myself, who don't practice in a kind of the immunocompromised or kind of hem-onc world, is there an easy way to remember them?
Well, fundamentally, they're antibodies, so they end in MAB, but unfortunately, that won't help you differentiate them from some of the MABs you already know and love, like rituximab.
That one's easy.
And
that's easy, though. That's the problem.
Right. Yeah. Sorry about that. There are 5 currently FDA-approved ones, and they span indications ranging from hematologic malignancies like multiple myeloma and lymphomas to solid tumors. And so some of the most recognizable right at this point are probably pembrolizumab or Keytruda, and maybe ipilimumab or Yervoy. And I have some bad news for you, Nick. There are literally thousands of ongoing clinical trials that are studying these and new compounds. So they're working their way into the market, as well as into first and second line therapy recommendations for things like non-small cell lung cancer. So practitioners in every ED and ICU are probably going to encounter patients on these drugs.
We're gonna need some cheat sheets ASAP for all of us there.
Me too. Me too.
This sounds kind of like there was I think it was a New York Times article a few months ago that talked about how they pick generic drug names, and it's literally, I think, a group of, I can't remember if it's 2 or 3 women in California. I'm wondering who is in charge of the biologic naming, because that sounds like they lost a straw vote, because that has to be one of the most underappreciated but also challenging jobs in medicine, is naming some of these agents.
Personally, I think they just reach into a bag of Scrabble tiles and pull some out.
Well, if that's the case, they're winning Scrabble. They're getting double and triple words on these.
Yes, good point. Good point.
Now tell us, how do these immune checkpoint inhibitors work? And maybe specifically, how are these different from more traditional chemotherapy?
So traditional chemotherapy works through different mechanisms, but basically mediates direct cytotoxicity. So we're killing our cancer cells and healthy cells alike with chemotherapy. And to understand the mechanism of immune checkpoint inhibitors, you have to think back to that second signal that's happening between the T cell and the antigen-presenting cell that can either stimulate or inactivate T cells. So what these drugs are doing are blocking that co-inhibitory molecule. So things like cytotoxic T lymphocyte antigen 4 or CTLA4 is a target here. And program cell death 1 or its ICANS, PD1 and PDL1. So they're blocking that co-inhibitory signal, which means that more of a patient's own T cells can be activated and proliferate to fight their cancer. So to put all of that simply, checkpoint inhibitors basically prevent the downregulation of immunity. So they're not actually a form of immunosuppression like we think of chemotherapy as being, but rather they're an immune system enhancement, which is why they fall under the umbrella of immunotherapy, using a patient's own immune system to fight cancer.
That makes sense. That's a great kind of comparison. Now, I joke it's probably not all sunshine and roses with these agents, because that's why you're here talking with us today. So what are some of the adverse effects from these agents? And then do we even know kind of why or the mechanism as to how they occur?
Both good questions. So we call them immune-related adverse events. So in the literature, if you're reading, you'll usually see it as little IR, capital AE. So immune-related adverse events. And basically, they're inflammatory side effects that result from overactivation of our immune system. Unfortunately, almost any organ system can be involved. Most commonly, we think of the GI tract, the endocrine glands, the skin, the liver, the lungs, the heart, the CNS, the musculoskeletal system, bone marrow, so a lot of them.
Almost everything, it sounds like.
Right, precisely. So I think the ones you're most likely to encounter in the ICU are things like pneumonitis, hepatitis, myocarditis, aseptic meningitis, and perhaps some of the musculoskeletal things like Guillain-Barré. And fortunately, the severe toxicities seem relatively rare on the whole. They're probably most common with ipilimumab, which is the lone anti-CTLA4 agent. And they also seem to be more common when different immune checkpoint inhibitors are being used together, which sometimes happens. And much of our knowledge about this comes from an amalgamation of phase 3 trials, case reports, and series, and systematic reviews. So you'll see really variable frequencies reported in the literature. But to give you an example, there's a pooled analysis of nivolumab-treated patients that showed severe treatment-related adverse effects, so grades 3 to 4, occurred in only about 2% of patients. Now, to me, this seems low because in my own practice, I feel like we're treating these far more often. I've had a patient, it seems like almost every week, who's being worked up for one of these, particularly pneumonitis. And, this is just as a disclaimer, this may be my own biased perspective, or maybe we're being quicker to diagnose immune-related adverse events when there's really another driver because these are on our radar now, but it's also possible that our real-world data is going to look different than clinical trial data. I'm not sure. We don't have the advantage of strict diagnostic criteria for any of these things, and so they're probably going to be a diagnosis of exclusion. They need to be on your differential diagnosis along with other, more common things like pneumonia, things like that. So unfortunately, the incidence is a little bit up in the air. So I'm sorry, that was a long-winded answer. I will get to the mechanism, or at least what we think we know about the mechanism. And unfortunately, we talked about how every organ system can be involved, and the mechanism behind toxicity in each organ system may differ. So, for example, one of the simplest theories is that maybe there's evidence that T cells are proliferating and then trafficking into areas that they just shouldn't be, where they cause local inflammation. There are also some T cells that appear to be autoreactive, and so they're responding to normal host antigens as though they're foreign. So that's why you can get some autoimmune type reactions. And then there is a theory where toxicity is related to cytokine release from the immune system activation, which is what we think is the case in colitis. So since the overall incidence of these adverse events is very low, and we don't often have things like biopsy data to help us uncover more, we still have a lot to learn about why they're happening.
Now, you mentioned the different grades and how the immune-related adverse effects kind of vary in severity. And you specifically mentioned grades 3 to 4. Are those the patients who will present to the hospital or to the ICU, or if they're experiencing any type of grade, they'll probably come in and be admitted as an inpatient?
So to just briefly let the listeners know, in case they're not familiar with this, most immune checkpoint inhibitor literature uses the National Cancer Institute's common terminology criteria for adverse events, or CTCAE, to grade the toxicities. And so they're grades 1 to 5, which simply put could be described as anywhere from mild, which is grade 1, up to moderate, severe, life-threatening, and then death is actually grade 5. So there are specific grading criteria for each organ system that are described either on the website of the NCI or the NIH. But in general, most patients would probably be hospitalized for grade 2 toxicities and require care when you get to grades 3 and 4 toxicities, which means in simple terms that symptoms are severe and patients require aggressive, if not life-sustaining supportive care. That's that grade 3 to 4 that would land patients in the ICU. And the presentations can vary depending on organ system involved. For the purposes of our ICU practitioners, for example, I think we see pneumonitis a lot. And so patients with checkpoint inhibitor pneumonitis have varying presentations, but often it's evidence of organizing pneumonia and ground glass opacities on chest x-ray with initial signs like shortness of breath and cough, or sometimes fever. And then myocarditis is another one that's, again, not common, but maybe one that could bring patients to the ICU. And so that could be anything like cardiomyopathy to arrhythmias, or maybe a pericardial effusion.
You mentioned with CRS that the symptoms can rapidly progress. What about with the immune-related adverse effects? Can they have that rapid kind of decompensation like you described, or do they remain fairly constant?
It can really go either way. And so some patients, again, will present with lower grade toxicities that just seem persistent and maybe never escalate to more advanced toxicity, and then other patients will decompensate rapidly. One thing that I do think is very interesting about immune-related adverse events, and that I wanted to share, was that their presentation in general can occur as early as the first few weeks after the initial dose, but it can also occur as late as 6 to 12 months after a single dose is given. And so this is one of the reasons why it's becoming more important for all pharmacists, not just those in hematology and oncology, to pay attention to what treatment their patients with cancer are getting now or have received in the past, because we've treated patients whose last dose was multiple months ago and they present with what we think is an immune-related adverse event. I would also say that the time to onset of that adverse event might determine whether or not we re-challenge with a different checkpoint inhibitor, and we can talk a little bit more about that later. I would also say that it is important to know that more than one of these can be occurring at a time. So it may be that patients are just exhibiting toxicity in two or more organ systems simultaneously. You don't want to rule that out.
Well, that point of pharmacists need to be more aware. That's why we're having you on today. So I really appreciate that. Now,
happy to help.
Now, how can we treat these adverse effects? Are there like guideline recommended algorithms to follow, or is it going to maybe vary, maybe slightly vary between, health systems or practice?
Well, there's both good and bad news on this front. Unfortunately, there are no comparative trials of safety or efficacy for the various strategies that we use to manage immune-related adverse events.
I'm glad you led with the bad news.
Yes, I did. We largely have adopted the approaches that were either designed for clinical trial protocols or we extrapolate from other areas of medicine. However, the good news is that the American Society of Clinical Oncology, or ASCO, has recently published guidelines that are based on systematic review and expert recommendations. So first, let me say that we need to be sure that the checkpoint inhibitor is held during the period of acute illness. We can talk a little bit more later about whether or not to restart and when. But otherwise, if I were to sum up ASCO's 60 pages of discussion in one word, it would be steroids.
That's a great summary.
Yes. Don't read the 60 pages. Just go to the table where it tells you how to dose the steroids. That is going to get you through 60% of treatment. No, there is definitely more art to it than that. Again, recognizing that this is largely based on systematic review and expert opinion. So that is the limitation here. But for now, it's what we have. So the experts would say that the dose should probably be based on the grade of symptoms, and it ranges from things like methylprednisolone, 0.5 milligram per kilogram for grade 2 toxicities, which again are the ones that patients are likely to present with on general care floors. But those doses can escalate to 1 to 2 milligrams per kilogram in grades 3 and 4. And so those bursts of 2 mg per kg are generally recommended for a short course, like 3 to 5 days, before decreasing the patient back to 1 mg per kg. And then the basic concept is to start a slow taper once symptoms begin to resolve, specifically to a level of grade 1. So sometimes I feel like I'm fighting against the dogma of 1 gram of methylprednisolone that we often give for DAH, which is another very frustrating discussion for me altogether. But I do think that it is important to point out that these doses of steroids really aren't huge that are recommended, so we don't need to be reaching for 500 milligrams or 1 gram all of the time. But there are a few exceptions to this that are notable. So some of the musculoskeletal symptoms like Guillain-Barré or encephalitis, where higher doses like 2 to 4 mg per kg or sometimes 1 gram per day are recommended for short intervals. And then there are some unique cases where things like IVIG or plasmapheresis are indicated. And then endocrine disorders are the other outlier because we're treating those with targeted hormone supplementation. So while you can say steroids is the answer to most things, unfortunately there are some cases that are going to be steroid refractory. And so the guidelines do touch on those for each individual toxicity. So for colitis, as an example, which is one of the most common toxicities, specifically with the CTLA-4 antibody ipilimumab, infliximab seems to make sense because it addresses the underlying mechanism of cytokine involvement. Vedolizumab is another monoclonal antibody that's used in inflammatory bowel disease, and although it isn't a fundamental part of the guideline recommendations, it has shown some promise in small case series of patients that present with colitis. And then in general, other rescue therapies for second-line use behind steroids include things like mycophenolate mofetil, and there are some new cases of successful use of abatacept or belatacept that have recently been reported in the New England Journal of Medicine. But the theme here is immunosuppression. So that makes sense considering that adverse effects are thought to be happening as a result of immune system overactivation. And it just gets back to what I feel like I'm constantly battling in my practice, finding the right balance of immunosuppression and immune competence or activation. And so there's still a lot about management that isn't known, like the timeline for treatment initiation, the treatment of choice for steroid unresponsive cases, and then how and when we down titrate steroids. And so unfortunately, because this is so new, it's also exciting, there's just still more that we don't know, and it would be wonderful if we could get some actual comparative quality prospective evidence to start addressing questions about treatment.
You mentioned probably trying to find that balance is always challenging, and these, if we're using immunosuppressive agents like steroids, we always have to consider the potential for negative effects. So is there any downside to using, like, for example, corticosteroids? Like, is there any bad things that have been observed?
Yes, in my personal opinion, there is always a downside, whether or not you want to think about it. So I think we often downplay the true risk of steroids, or at least casually dismiss them as unnecessary evil. In the case of immune-related adverse events, we do have some data to describe the trade-offs, at least in the initial phase of discovery. There was a nice study published in PharmD back in 2016 that showed infectious complications developed in as many as 7% of individuals that were treated with steroids for immune-related adverse events. And the use of steroids overall resulted in a 7-fold risk of infection. So significant risk of infection here with steroid use. And I think this is also a transition of care concern because we are often discharging patients not just from the ICU, but from the hospital on prednisone at doses of 20 to 40 milligrams daily or sometimes more. And we're just trusting that they'll follow up in the outpatient setting for close monitoring and symptom-guided tapering. I can tell you from personal experience that that doesn't always happen. I unfortunately saw a patient die from PCP pneumonia after having never been tapered off for 80 milligrams of prednisone in the 8 weeks following her initial hospitalization. And of course, she was not prescribed PCP prophylaxis in that case. So when we use them, we need to be considering appropriate preventative care. So PCP prophylaxis, peptic ulcer disease prevention in high-risk patients. And we need to be doing our best to make sure that these patients are being appropriately followed up after hospital discharge. I would also say that beyond infection risk and some of the long-term complications that are associated with steroids, there is some debate about whether or not the efficacy of immune checkpoint inhibitors are blunted by steroid treatment. So there's a pooled analysis of patients treated with nivolumab, and those who received immune modulating agents like steroids did actually not have a worse objective tumor response rate. And then similarly, in an ipilimumab trial, there was no difference in overall survival or time to treatment failure when steroids were used to treat an adverse event. But this data doesn't exactly agree with some of the earlier phase data on immune checkpoint inhibitors. And so, in my personal opinion, I don't think we're ready to say conclusively that steroids have no effect on the efficacy of this treatment, but at least our more recent data is looking promising that we can use steroids perhaps without major downsides on the overall survival and treatment response.
And this is kind of a strange question, but is there any correlation between seeing these adverse effects and knowing that your treatment is actually working?
I think it is a very intuitive question. I think it's a great one because it's easy to see from a mechanistic standpoint how that would make sense. If you're trying to activate the immune system to fight cancer, it stands to reason that if you do so well enough to incite an immune-related adverse event, that ought to mean that it is working. And there is some controversy on this topic. There was a pooled analysis of the nivolumab-treated patients that I referred to earlier, published as recently as 2017, that said the objective response rate was significantly higher in patients who experienced an immune-related adverse event of any grade. So 49% compared to 18%, which at least to the naked eye, looks like a pretty significant difference for those who experience an adverse event. But conversely, in ipilimumab-treated patients, there was no difference in overall survival or time to treatment failure when the analysis was stratified according to whether or not patients received steroid treatment for that immune-related adverse event. So that suggests maybe that having an adverse event wasn't associated with improved outcomes. So as with the question about whether or not steroid impacts the outcomes of cancer with ICI use, I'm not sure we have enough evidence to definitively say that having an adverse event means that the drug is working. However, I do think this brings up the issue of whether or not we should be re-challenging a patient with the same immune checkpoint inhibitor or a different one after they've had an immune-related adverse event. And so while this certainly is not a conversation you're likely to have in the ICU in the wake of an adverse event, and maybe not even in the hospital, it's an interesting question. And so the idea is to keep the therapy on hold until symptoms resolve to grade 1 or better before you reintroduce it. And there are a lot of people who won't even entertain the idea of re-challenging a patient, depending on the severity and the type of immune-related adverse event. So, for example, myocarditis and pneumonitis that are severe often result in the patient being taken off the therapy permanently. So, again, there are not specific guidelines to tell you whether or not that's the right thing. But it's interesting. There was a paper in JAMA recently that looked at patients who were retreated with an immune checkpoint inhibitor after the occurrence of an immune-related adverse event, and found that about 50% of the patients experienced a recurrent event. And that trend made it look like there was an increased risk of recurrence either with advanced severity of the initial event and then a shorter time to onset. So say, for example, if the immune-related adverse event with initial therapy happened 3 weeks after their first dose and was severe, grade 3 or 4, perhaps that's the patient who's most likely to experience a recurrent event if you re-challenge them with the therapy. And I think this is important to ask and interesting to talk about because of the significant effect that these treatments are having on cancer outcomes. We're really extending life, and we're being able to affect positive change in disease states that have previously been very refractory to therapy, like non-small cell lung cancer. And so the last interesting thing I'll mention about this paper in JAMA is that they looked at the groups that were and were not re-challenged with a checkpoint inhibitor, and they did not differ with respect to median progression-free survival, which means that patients might not actually have to be exposed to very much of this drug to see a significant survival benefit. So overall, this is just a very interesting and curious class of drugs, and so I'm interested to see how the knowledge evolves.
I couldn't agree more. That's extremely interesting and good. And all of the, for the listeners, all of the papers that and guidelines and things that Heather has referenced will be on the reference list, just like with previous episodes. Now, if you had to have a list or kind of a like a top 5 type of thing of the most important things to consider and remember when treating patients who have received immunotherapy, what would those be? And I'm asking because this might save some frantic Googling from myself and some of the listeners when, one of these patients possibly unexpectedly presents at, of course, like 4 or 5 p.m. on a Friday.
Right. Well, with the pace of the field, I'm going to be honest, you might still want to do some Googling just because it's quite possible that 2 days after we record this and it's released, something major changes, or there's a new player out there that behaves differently than the other ones. And so one of the things I think is really important is to phone a friend when you need to. So we should be having constant conversations with our hematology and oncology colleagues. I really don't believe that there is a field in which advances are being made more rapidly than in cancer. And it's just impossible to keep up with this on your own. I deal with an ICU population that almost exclusively has cancer, so I see this day in and day out, and I still feel like I am so behind. And so I rely on my colleagues that practice and specialize in hem-onc to help me make sure there's good communication, collaboration, and, we get prepared for things before we introduce a new treatment that could land the patient in the ICU. So I think that is one thing. Phone a friend. Don't be afraid to do that. The other two parting things I would say, with CAR T therapy, it's important to be prepared. So people, everyone from providers, fellows, advanced practice providers, ICU nurses, a pharmacist, everybody needs to be educated and trained, and your processes need to be prepared so that you are able to deal with a rapidly decompensating patient. And I think patients, or centers rather, that are giving CAR T therapy are doing this. You really need to be accredited. But we should be a voice for the ICU interests. Absolutely, we don't want to be left out. This therapy isn't just impacting for hematology patients. So start that conversation. And then with immune checkpoint inhibitors, don't forget to, look for horses, not just zebras. So if a patient presents with respiratory distress and has non-small cell lung cancer, it's very possible that he is experiencing progression of his cancer or a regular old pneumonia or a COPD exacerbation. But it's also possible he is experiencing checkpoint inhibitor pneumonitis. So you have to consider the things that we've talked about in the differential, but largely right now they're diagnoses of exclusion. So don't be afraid to work up multiple things at the same time. And if your patient is rapidly decompensating and you want to add steroids for that patient because you think that this could be an immune-related adverse event, that's great. Just don't be afraid to reevaluate that in the coming days. I have to say, I will never be bored because we talked a little bit about the balance between immune system activation and immunosuppression and trying to find the right balance. So whether it's toxicities associated with drugs or infections, there's just always, every patient is unique and every patient has a different number of risk factors and experiences that weigh on either side of that teeter-totter. And so you just really have to consider them one by one. And so just avoid the one-size-fits-all sort of lens looking at these patients.
I think you all just gave everyone some comfort knowing that, this is these patients, almost exclusively present to your ICU and you feel overwhelmed with the amount of literature. And I know I can definitely speak for myself in that, I don't routinely treat these patients and I'm very overwhelmed with the amount of literature and how it's evolving. So that point of phone a friend, reach out, I think that applies here and probably in so many other places as well. So that's a really, really great first point. Heather, this was so much fun. Go ahead.
It's so exciting to talk about this stuff. One thing I think, this cancer therapy is cool, and if you can tap into the nerd in yourself and not worry too much about keeping up with the literature, but just appreciate the neat advances that we're making, I think it's really important to stop and take time and see how far we've come.
Secretly, I think most of us are probably at least have an inner nerd. Maybe we're not all nerds, but there's a part of us in it, in the pharmacy and medical field. I think that we all share that kind of common bond.
I agree.
This was so much fun. Heather, you're great, and I learned, a whole lot, and I think the listeners absolutely will as well. Now, what's your Twitter handle for anyone who may want to reach out and get in touch with you?
Oh, it's at hpersonette_May. So HPERSONETT_MAY. And I am admittedly a novice Twitterer. I'm an aspiring Twitterer. So anybody that can help engage me and help me practice my skills, I'm open to that.
Everyone go give her a follow. And Heather, appreciate you. Thanks for taking the time to join me. This was really great today.
Absolutely. Thank you so much for having me. And thank you for the people who downloaded and listened.
Now, another huge thank you to Heather May for taking the time to join us today. And then, of course, I also want to give a massive thank you to you, the listeners, because this podcast does not exist without you. So send me feedback, positive and negative, as well as any guest or topic ideas. We're on Twitter and Instagram at Pharmacy to Dose. That's TO to Dose. Or via email at pharmacytodose@gmail.com. Now, on our website, that if you haven't visited yet, has been newly renovated and is a little easier, I think, to navigate. So definitely pop in and check out the website if you haven't been or you didn't like the layout initially. But you'll find show notes from our discussion. It's going to talk, some background readings, the articles that Heather and I referenced, guidelines, and much more. So definitely check it out. And Heather and I would love to hear from each and every one of you, so definitely reach out, stay in touch. And until next time, I'm Nick Peters, and this is Pharmacy to Dose, the Critical Care Podcast.